Thank you so much for the kind introduction, and I'm very happy to have the opportunity to present our research findings at 11th IVHEM 2025 in Korea. So in recent years, there has been growing interest in the risk of HCC and the benefits of antiviral treatment for chronic hepatitis B patients in the gray zone or indeterminate phase. So in this study, we investigated the cost effectiveness of all antiviral therapy in these patients. And this study was mentored by Professor Young Sung Lim from our center. So these are my disclosures. And there is growing interest in the gray zone of chronic hepatitis B, a group of patients who don't fit into the traditional natural history of the chronic hepatitis B based on their ALT levels and HBV DNA levels. And actually, evidence is accumulating that these patients actually have a higher risk of developing HCC. So indeed, in a previous study, approximately 39% of patients were in the gray zone or indeterminate phase at baseline. And after nearly 12 years of follow-up, only 22% transitions to the immunactive phase, while 50% remained in the gray zone. So importantly, the risk of HCC in these patients was nearly 14-fold higher compared with inactive carriers. So in patients in the gray zone, HBV DNA levels had previously been considered to have a linear relationship with HCC risk based on the Libel HBV study, which means that as HBV DNA increases, HCC risk also increases. However, in this cohort, 85% were HB antigen negative, and even 50% of the patients were inactive carrier. And due to technical limitations at the time, HBV DNA levels above 5 log could not be analyzed. So in our previous study, which included more than 30% E antigen positive patients and extended analysis to higher HBV DNA levels above 5 log to complement the Libel HBV study, we interestingly observed a parabolic association between HBV DNA levels and HCC risk. Specifically, patients with moderate viral load between 4 to 8 log had the highest risk of HCC, and notably, baseline HBV DNA levels continue to influence on-treatment HCC risk, even after the initiation of antiviral therapy. So in other words, patients who initiated treatment at HBV DNA levels above 8 log maintained the lowest risk of HCC, underscoring the need for all initiation of antiviral therapy based on HBV DNA levels, regardless of ALT levels. So thus, in this study, we aim to assess the cost effectiveness of initiating antiviral therapy in the gray zone, particularly for patients with HBV DNA levels between 4 to 8 log and normal ALT levels who have considerable risk of developing HCC. So we conducted a cost utility analysis using a Markov model to compare the expected cost and quality adjusted life years CALIS. So we compared the group 1, treat gray zone, in which patients received antiviral therapy in the gray zone, with group 2, untreated gray zone, in which therapy was delayed until progression to the immunactive phase, accompanied by ALT elevation. As shown in this Markov model, patients were allowed to transition between health states, including gray zone, immunactive phase, inactive carrier, and viral suppression, and surface antigen loss. So the hypothetical cohort consists of 10,000 patients, of whom 60% were male, with HBV DNA levels between 4 to 8 log, ALT levels less than 40, and 50% were E antigen positivity, and was simulated over a 10-year horizon. So transition probabilities and costs were derived from a Korean multicenter cohort study and previous references. And since antivirals aren't reimbursed in the gray zone, the data are limited, so we borrowed from immunactive phase patients, where HCC incidence was 0.64% compared to 1.26% in untreated gray zone patients. So for viral suppression, we used published rates, 93% in year 1 and 99.3% by year 7. And drug cost for tenofovir and entecavir were based on Korean prices, and the incremental cost-effective ratio, ISER, using CALIS, was analyzed from both the healthcare system perspective, considering only direct medical cost, and the societal perspective, which additionally accounted for productivity loss due to premature deaths. So as you can see in this table, the annual incidence was 1.26% in the untreated gray zone group and 0.64% in the treated gray zone group. And the ICER was calculated at 12,050 USD per collie, which was below the willingness to pay threshold of 25,000 USD per collie over the 10-year time horizon, indicating that early treatment in the gray zone was cost-effective. And in the probabilistic sensitivity analysis, the average ICER of the simulation results was 11,000 USD per collie. And the treat gray zone strategy was found to be cost-effective with a 77.7% probability at a willingness to pay threshold of 25,000 USD per collie. So when analyzing ICER according to the HBV DNA levels, HS risk in the gray zone demonstrate an inverted U-shaped pattern with the highest HS risk between 6 to 7 log, whereas ICER followed a U-shaped curve reaching its lowest point at HBV DNA levels between 6 to 7 log. So antiviral therapy was cost-effective across all HBV DNA strata. Moreover, from the societal perspective, the incorporated productivity loss therapy yielded negative ICERs at HBV DNA levels between 5 to 7 log, confirming it as a dominant strategy with actual cost-saving benefits. So in the ICER analysis by age, ICER values decreased with increasing age. Among patients in their 30s, cost effectiveness was not achieved under the healthcare system perspective that considered only direct medical costs. However, when productivity loss was additionally incorporated under the societal perspective, antiviral therapy was cost effective across all age groups and even demonstrated a dominant strategy when the patient's age is over 40. So in the one-way sensitivity analysis, age at treatment initiation, analytic perspective, and HBV DNA level were identified as the most influential variables affecting cost effectiveness. When we looked at the cost effectiveness acceptability curve by HBV DNA and age, antiviral therapy was cost effective in over half the cases except for patients in their 30s. So when we compared the medical costs across countries, the ICERs came out to about 82,000 USD in the United States, and 1,370 USD in the UK, and 21,000 in Australia, and 21,000 USD in China. So even though the numbers look quite different because of the big differences in healthcare systems in each countries, they were all still below each country's willingness to pay threshold. So overall, the treat gray zone strategy was cost effective across all our settings in other countries. So in summary, initiating antiviral therapy in patients with high viremic gray zone was more cost effective than delaying a treatment until progression to the immune-active phase. The therapy became increasingly cost effective as HS risk increased, with a U-shaped association observed between baseline HBV DNA levels and ICER. So these results carry important implications for managing chronic hepatitis B, guiding clinical decision-making, and optimizing allocation of healthcare resources. So thank you for your attention.